seems like we almost have too many systematic reviews, just reviews of reviews, and the real questions are being answered with high quality clinical trials. And I think the more of those that we get, then your systematic reviews become more meaningful.
All right, next guest, Dr. Gail Deyle, clinician-scientist, educator, and one of the strongest advocates for high-quality, evidence-based physical therapy. His research and writing have appeared in the world's top medical journals, and he spent his career showing that great PT care isn't just effective, it's safer, cheaper, and often better than the alternatives. How'd I do on the intro?
It did great.
Welcome to the show. Thanks for coming out here to the conference.
My pleasure.
Yeah. How many of these you been to?
Most of them. I've probably missed one or two over the 30 years, but usually I'm here.
What's changed and what's stayed the same?
The number of new fellows every year has gotten larger, which is good. We have more programs, and one of the threats against some area of practice specialty that's as specialized as we are is that there's not very many of you, and so you can create demand, but if the supply is not there, then it becomes a problem. So it's good that the academy is growing and the number of fellowship graduates we have is growing.
Yeah, one of the speakers in the room said something like, I was fellow number 63 or something like that. So seeing where that's grown is...
my number is 6.
So you're 6? You're single digits. You're even newer than 007.
Yeah, I'm one short of the big time.
Gail, you've often said PT is the low-risk, high-benefit option for chronic conditions. What data or stories best drive that point home for policymakers? What actually moves the needle?
Well, I think where this has been looked at, both from a cost perspective and an outcomes perspective, the outcomes are really very comparable. And in many cases, better than what you see with medications and injections. And we actually published a clinical trial in the New England Journal of Medicine. In most people with NEOA, a very prevalent chronic condition, the first treatment they get is a steroid injection. And oftentimes the providers will say, well, we want to give them immediate pain relief. We have to do something. And yet then in our clinical trial, the short-term pain relief of manual therapy was superior to steroid injections in the short term, the intermediate term, and in the long term. And so there really is no downside to this. It's just, one, you have probably large pharmaceutical companies pushing their medications, and then it's easy to get into that pathway of you get your MRI, and then somebody sees some degenerative changes in the meniscus or whatnot, and that leads them to a surgeon's office, and surgeons, and again, they may fully believe in what they're doing, but there may be lower risk alternatives to that whole pathway.
Yeah, it's storytelling, right? When you give some of the hammer, the world's full of nails, right? And when you give someone a prescription pad, maybe that might feel like the only option, but there's other ones. So it might come down to storytelling and being able to make sure people understand clearly and concisely what their options are.
I think oftentimes things like total joint replacements, people feel like that's their right to have that. Yeah. And then once they're told, a few, I think, just dismaying things clinically. And so when someone comes to see you, you're their primary care provider, or maybe you're their surgeon, and you say, well, you have degenerative disc disease, or you have, these changes to your knee, your bone on bone. Well, that just sounds so there's no hope. And so the only thing that's going to change that situation is going to be this total joint replacement. And maybe in the short term, I'll take medications and get my knee joint injected. Where if indeed you started them on a good conservative pathway, they may never need a total joint, or they may do just fine for 20 years and then need one. And so then they're not going to need to have a revision surgery, which is riskier and outcomes are usually not as good. So it's kind of changing that mindset that a lot of people in the in the chronic condition population have, that they're somehow entitled to get these back surgeries, or, the only thing that can help them is that, or the only thing that can help them is if I get my knee replaced.
Yeah, sometimes people look at it as, well, it's inevitable, the inevitability of that thing. And it's hard to fight that when someone believes that that's the course of life. It's hard to get them out of believing that. It's hard to unlearn or unteach someone something, especially when their peers around them might be reiterating the same message.
And the risk thing, and in general, the risks with total joint replacement are low, maybe even getting to the point of minimal. But when you have a complication, it's substantial. You can bleed to death. You can become infected. You can have loosening of the prosthesis, and it could be that it's a very short time before you need to have your revision surgery done. Not 10, 15 years, but 24 months or so. And it's just the fact that I could engage on this highly effective program without these potential risks. And at Brook Armory Medical Center, we had someone who helped us with our pool program, and she was an AK amputee from a failed total knee replacement that got infected, and those are some of the things that can happen. Fortunately, they're not frequent enough that they get a lot of attention. But one of the places I go, I spend summers up in Alaska, and a few years ago when I was up there, big thing on the news, there was this beloved professor from the University of Alaska Anchorage died on the table getting his knee replaced.
Wow.
And there is no such thing as a risk-free surgical procedure. Sure. And so, if you've got good alternatives, and it's like Steve Kerr said when he ran into his spinal headaches after they nicked his dural sac and all that, he said, do your rehab, and do some more rehab before you let the surgeons in there. Yeah,
some good endorsements there from Coach Kerr. Easy access to PT can cut opioid use and lower overall costs. So why hasn't the system caught up yet? If we know that, we can measure that, we can look at a spreadsheet. Why hasn't the system caught up?
I think it's a complex question. I think for one, there are no incentives. I mean, if you watch any television with advertisements, look
Sure.
at what all the advertisements are. And so there's powerful incentives, and physicians are bombarded with pharmaceutical salespeople, and and there's just lots of incentive to prescribe certain things rather than think about. And they will say, and there probably is some, that they're under some pressure from patients who demand those things. But I think that 5 minutes worth of counseling and say, hey, there's a much lower risk alternative. Maybe if we need to, we can do some acetaminophen or something like this, something that isn't going to tear up your stomach like your nonsteroidals or so forth, and we'll get you on a rehab program. And it could be, and that's what we have found, is that with all of our NEOA clinical trials, the medication use drops off. People no longer have their symptoms, and they're not on daily medications, even though oftentimes we kind of say, well, just continue what you've been doing so we keep that stable. But by the time you get to the end of the trial, they're like, I don't need that anymore, and I'm not doing it.
Yeah. You've worked inside the military health system. You mentioned that.
Mostly.
Yeah. What lessons from that model could civilian healthcare adopt to improve efficiency and outcomes from your perspective, a good insight and perspective?
Yeah. One of the things that with some of my mentors, and I spoke on that today, they initiated physical therapists as frontline providers for musculoskeletal conditions. So that facilitated the access. You don't have to go through primary care. You don't have to go through all these little steps or hurdles in order to be able to see someone who is a musculoskeletal expert. And that also means that, maybe evaluating you for your condition and treating you can occur all in one session. Yeah. And so that respects the patient's time, and it's more efficient for the healthcare system. And, the earlier, that's one of the, I think, the true constants through most of the literature, the earlier access you have to good rehab services, you decrease the rate of musculoskeletal conditions becoming chronic and the demand for opioid medications and in the very end surgery. And that may be a little scary if you're a surgeon, and so maybe that's one of the incentives not to facilitate a facilitated pathway to a musculoskeletal expert like a physical therapist.
But from my understanding, as someone who's never been in the military or government, they typically take a long time to make a decision. When they do, they've looked at it and said, this looks like the path with the least resistance to the best return. If anything, our government moves slowly, but when they move, they take a long time to a decision. For them, from my point of view, for them making PTs frontline providers says, hey, they've got something here. If the government's actually willing to do it, right?
Well, I think that's partially true, but a little more so that the for-profit incentive is not there in the military health system. In other words, nobody's making money by replacing knees and doing spinal surgery. I mean, if they're in a training program, they get necessary experience and so forth. But they were really more than willing to let physical therapists take this burden of patients, and the models were, the beta sites were so successful that it just spread throughout what was first the Army and then made its way throughout the entire military health system, the Air Force, Public Health Service, Navy. It's just, okay, our musculoskeletal expert. And it even, like at Brooke Army Medical Center, when I was chief of physical therapy there, I seeded some of my fellowship-trained physical therapists into primary care clinics so that when somebody showed up there and maybe they were getting their asthma or diabetes checked and they started talking about their neck or back pain, they say, we got the guy to see right here. We got a guy right
down the hall. But you've got to be there.
Yes.
Right? That's the importance of physically being there. We had a guest on earlier talking about physical therapists in the emergency department.
Same concept.
Right, yeah. Make sure you're there. Proximity can sometimes be your biggest weapon.
Yeah, and that, and if you've ever been in the emergency room, if you have kids or something, you're sitting there and you see some poor guy with a sprained ankle that's sitting there for 6 or 8 hours with his ankle getting bigger, and if he'd have either had direct access to a physical therapy clinic or could have seen a physical therapist there, you could just,
You've been gone.
Tell him what he needs to do, get him on a pair of crutches and get him back home.
But he's going to keep getting skipped over by the people who are a higher need, which is important, right, for triage.
Right. Exactly right.
Except you could do both.
Yep.
Yeah, with our profession. So how can clinicians at a grassroots level become better advocates for access and reimbursement reform? What would you tell for people to actually do that? What could move the needle? We've been told since I was a student, advocate. But from your point of view, what really moves the needle for them?
Well, that's a challenging question. That's probably the point where I'm not the best. I'm a little bit of an introvert. And so, I'm not the guy that just walks up and shakes hands with everybody in the room. But I think PTs have to be more political animals. And I think you need to know your legislators and you need to offer to support them and you need to help in their campaigns and so forth. I'm not so sure that contributions do all that much. But, if they get to know you and they know that you're working for their behalf, they're more likely to listen to you. And then I think if legislative issues, and like in Texas where I'm from, it was really painful to get direct access implemented. We were one of the last states to ever implement that. And even now we don't have the reimbursement that we need from that. So now you're talking about healthcare policy at the national level, Medicare, Medicaid, those type things. And certainly you do have to have congressional influence to be able to make changes there.
Yeah, people-to-people connection. Big on evidence. AOMP's members are passionate about evidence. What's the next frontier of research we need to pursue to keep strengthening our case for the value of PT, something we talked about at the beginning of this conversation?
Well, I think individual clinical trials are still really important, and I think that clinicians are experts in coming up with, what's the next clinical question. Now, they may not always be so informed on the literature. Maybe they have to do something intentional or purposeful to go back and say, I think I'm seeing this. I've made this clinical observation. What has been done around it? where's the gaps in the knowledge here? Okay, that informs me. So here's my question. Now what you need to do is you need to pair with somebody. Just somebody in a small clinic somewhere trying to do something that's going to make its way into the annals of internal medicine is probably unlikely. But you could partner with the university, or there's researchers out there looking for things to do, and here you've got a clinical question and maybe even a population of patients from which you made your observation. Now it's starting to look like this is something that's going to happen. And I think we need more of that. And, sometimes it seems like we almost have too many systematic reviews.
Yeah.
Just reviews of reviews, and the real questions are being answered with high quality clinical trials. And I think the more of those that we get, then your systematic reviews become more meaningful.
So is the message, if you're a clinician, you don't need to become a full-time researcher to participate in research?
Absolutely.
Because it sounds like both, researchers need clinicians and vice versa.
In all of our research efforts, and I was a little biased. I never really attempted to get a grant with any of our research. And, one of my colleagues at one time was not very positive on grants, and we just pretty much took it out of hide, our personal time in addition to all of our other duties. But I did work collaboratively with some very smart people and wasn't attempting to do all this on my own. And yes, we made some mistakes, and I think some of our early clinical trials, by today's standards, if you look at the metrics and, they're rated such and such on whatever scale, they got stronger. But then those standards also evolve over time. So you can meet the standards now. 20 years later, the
Sure.
standards are going to be a little different. And they might say, well, there's limited validity of this clinical trial. Well, it was fine for then, but today's standards are a little bit different. But definitely that collaboration between academic centers and clinicians is really a valuable thing.
Yeah, agreed. After decades of both a scientist, hands-on therapist, what still gives you optimism about where the profession's going?
Well, I don't think the demand is any less.
Okay.
I think that, there's a whole bunch of people my age that are heading into this time when we're going to need lots of care. I think the age groups behind us are not going to be much different. Sports is one of these things, and sometimes we get confused about what's fitness and what's sports and all that, but people are still injuring themselves. They're still probably over-challenging their musculoskeletal system and so forth. So I think the demand is high for expertise in this area, and it will continue to be so. I like to think of physical therapy as still a profession that's in its infancy. We've not even begun to realize what our full potential is. And I think one of the real positives is that there's physical in our name. And physical stimuli are positive stimuli to most things in the majority of human systems, even when you think of stuff that we don't generally work with, but like the GI system and cardiovascular system and pulmonary system. Physical stimuli have their effect on that, and we just have to get good enough and smart enough to be able to figure out what are the right stimuli and how do we apply those. And I think the future looks very positive as long as people stay motivated to explore the outer reaches of our practice sphere.
All right, last thing we do on episodes is called the parting shot. Is there an idea, a concept, a quote, or something? What would you want to leave with the audience today as we wrap up?
For the audience or for clinicians?
Anybody who's listening. You can pick who the audience is specifically.
For clinicians, I would say stay humble. People are complicated. Most of the problems that we deal with are complicated. I taught a course at one of the entry-level programs they recruited me for on complex patients, and I just kind of spun my head around, and just the suggestion that some patients are not complex. And I think that everyone I see is complex, and it requires all my experience and skill set to bring every single person to the full potential. So I would just say stay humble. If you get to a point where you think I've got this, Yeah, you need to get hungry again.
Old Dunning-Kruger, make sure you check yourself and stay humble.
Yes.
Yeah, Gail Deyle, we appreciate the time here
All
on
right.
AMPT.
I appreciate your
Thanks,
time.
man.
Thank you for the opportunity.
Thanks for listening to Hands On, Hands Off, the official podcast of AOMPT. Subscribe now so you never miss an episode, and connect with us at aompt.org or at AOMPT on social. Opinions are those of the guests and not official AOMPT policy. See you next time.